Welcome to Voice for Infection Prevention, where we explore the latest developments, challenges, and insights in the field of infection prevention and control. With a passion for promoting patient safety and healthcare excellence, we're excited to bring you engaging discussions with experts, leaders, and innovators in the field. So whether you're a seasoned professional or just beginning your journey in infection prevention, welcome to the conversation. This is Voice for Infection Prevention.
Welcome back to the Voice for Infection Prevention. I'm your host, Jacob Hutcherson. I'm excited about today's episode as we welcome a rising star in the field of infection prevention, Marko Predic. Marko currently serves as the Division AVP of Infection Prevention at HCA Capital Division. With his MS degree and CIC certification, Marko brings a fresh perspective and an innovative approach to infection prevention. In this episode, we're thrilled to explore Marko's journey and glean insights from his experiences as a forward-thinking IP. Join us as we discuss his strategies, challenges faced, and recommendations for aspiring professionals in the field. From leveraging relationships to navigating complex healthcare systems, Marko offers a blueprint for success in infection prevention that centers around continuous learning and hard work. So, without further ado, let's dive into our conversation with Marko and uncover the keys to driving positive change in infection prevention.
This episode is sponsored by Clutch Recruitment, the leading recruiting firm in the country, recruiting exclusively within infection prevention and control.
Gotcha, not a problem. So started out career, went to University of Florida with full intent of going to medical school. 100% the plan until about my senior fall. We had somebody come in and an IP present to us and say, we were in a parasitology class. We said, how many of you want to be a physician? 99% of the room. They said, how many of you considered a career in the medical field that you get to impact every patient? And we all kind of were puzzled. And it was, what do you do? And it's, well, I'm an infection preventionist. So kind of explained the field, definitely piqued my interest, at least because medical school is not like, I was like, yeah, let's do that. I was getting ready to go next year. And I was like, you know what, let me get my master's and see. So called my school up, deferred for a bit and said, let me go get my master's, see what this is about. Got my master's. As soon as I entered into my master's program, I connected with our local infection prevention program, and I interned from about week 2 of my master's through the end. And I think that was also very crucial, but fell in love with it, got hooked, met a lot of great people who mentored me through it, and just stuck with it ever since. It's definitely something where if you're on the fence about it, give it a shot. Go take a look, intern, just shadow, just see what they do, because no day is going to be the same.
Gotcha. So let me stop you there. You talked about the kind of doing an internship. Was that a paid internship as part of your MPH program, or was this something you completely did on your own?
Yeah. So for mine, it was completely because I was a Master's of Science in Epi. For the MPH programs, a lot of them had a 1 semester where they had to do it. But no, I took the initiative. It was unpaid, but I took the initiative because the experience is invaluable. It is a tight-knit field. You meet people and you'll know them across the country throughout your career. So learning that, I just got in, and it started with 2 hours. And at first, all I was doing was clearing notifiables. And then it kind of, they got me going into looking at cultures, getting the background, took me out rounding. So just getting in, even if you have an hour or two, ask them, how can you help? Like, what can you do to lighten their load on their day? And yes, there's some upfront that they're going to have to teach you. But again, the benefit is you're helping that team, you're learning, you're kind of putting yourself in their shoes, and it's helping you to see how are they thinking about these processes versus how do I think about them if I have no idea what they do.
Okay. And I've talked to a lot of people kind of at that stage trying to figure out like what to do, and that's kind of been my general advice, but can you give more specifically and really practically, like you had a hospital that was associated with the university you were at, correct? And then you just walked in. Did you find the director of infection prevention and just say, hey, what can I do? Is that how that worked?
So I got connected through one of my professors. She actually used to be an IP in the program, and she connected us. She just said, "Hey, I know the director of IP. Do you want me to put you in an email?" And she connected us and said, "Hi, I'm interested in interning. Anything or everything. What do you need me to do? Like, how can you find a use for me?" I gave them kind of what my background was, and they found a spot for me. Most facilities in our area, and I was in Gainesville, so I did UF. North Florida also took interns. So if one facility said no, my game plan was always to go to the second. So that it worked out, but ultimately it was just saying, "Hey, I'm here, I'm available, I have these hours. How can I assist?"
Awesome. And you did that, so you completed your master's degree? Is that?
Yeah, I did it for a year and a half. I completed a semester early, but that whole year and a half interned, made the connections, and ultimately that led to my first position at UF Health Jacksonville. So I did move to Jacksonville for it, but a lot of those connections kind of enabled me to make that jump into the career immediately, which I know is a little difficult at times to do.
Yeah. So, and then just to be clear, you were spending 1 or 2 hours a week for that year and a half?
So it was actually more. I was probably doing 2 to 3 hours a day most days a week. I was
Okay.
coming in, I was trying to make it as feel as full time as possible. Like, what is it that they do? Because again, I think investing 1 to 2 hours, by the time you're oriented to your master's program or your semester, it's going to be pretty quick, and you're probably doing a project, so you're spending 1 to 2 hours a week on whatever your project is for graduation, or if it's a research project. But doing multiple hours a week, and I came in early. I asked the team who comes in the earliest. I was getting in at 7 a.m. First class was at 9. 7 to 9, I was shadowing, rounding, doing what I could. I'd go back in the afternoons if I had time. So I spent a ton of time with that team, but it kind of gave me the leg up when it came to I applied. I had no real experience of I've been an employed IP, but I could say I've had a year and a half of where I functioned. I can do everything. I know the definitions. I know what to look for, and I think that definitely helped compete individuals who may have been nursing, may have been micro, because they didn't have to teach me the job, and I could learn the rest of it as I went.
Yeah, that's awesome. Wow. Okay. So then let's see. Let's jump forward then. You said this ultimately led you to your first like true infection prevention job in Jacksonville. Um, is that one you just saw an opening after you graduated, applied, they took you in, you relocated for the
Yeah,
job?
something like that. So it did help because new incoming director did come from UF, so they kept the program stay in touch, and they had a position open. So I got told about it. I applied, but pretty much applied. Went through about 2 rounds of interviews. They liked me, picked up, and moved me and my now wife. So just took a leap of faith. I do think at times that is necessary for some of these IP positions. Um, if you want to get a shot, you may have to move out of your little local area at times. It can be difficult, it can be challenging, but I'd say it's worth the risk, especially with how much where you can go after you get into the field. It kind of expands your horizons.
Gotcha. What was that first role? How big of the facility? Who'd you work with, or what was the team like that
Yeah,
you were with?
absolutely. So we were a level. It was a level one trauma center, academic teaching center in Jacksonville, Florida, UF Health. It was, I believe, it was about 770 beds. We had a fairly large team at that time, and I believe it's still the same size. It was a director, one manager, and 4 IPs, which grew to 5. So fairly large. The way they divided the work up was mostly by unit. We had designated unit rounding, which shifted every set time frame, and so you kind of learned every unit, the cadences. You were on NICU one a couple months, ICUs. It was a great immersive experience. And then we did all the ancillaries, the endoscopies, radiology, did all that behind the scenes, teams and pairs as it came up. So definitely a great learning experience starting at a facility that size.
Gotcha. Okay. So, what was the makeup of your team? With you being a non-nurse, were you the only non-nurse in that team, or were there others that had a similar background, or what was that like?
Yeah, so the director thankfully was an MPH, similar background to mine, microbiome undergrad, MPH. Then our manager was a nurse. We had 3 seasoned nurses on that team. It was 2 initially. I think they brought on another. Then it was myself, who was an MPH, and then we actually had an individual who was a veterinarian in another country came over and found her feet in infection prevention, and she went on. She's now a very successful director at the Mayo Clinic in Jacksonville. So every background kind of pitches in.
Very cool. Okay. Well, I've got a couple questions. I'm curious as to, number one, what was the transition between the internship to a full-time IP? I feel like after a year and a half, you probably have a pretty good sense if you understand what's going on. Was there anything that when you jumped in full-time, you were like, shoot, I wasn't prepared for this, or not quite what I was anticipating?
Yeah, and I don't think I didn't have those experiences. I never woke up and said, I think I'm out of my depth. I think the biggest transition was I am now here full time and everybody sees me as the expert. And it was there I had to have a realization. Sometimes I wouldn't know the exact question they were asking, but I needed to find out, where are my resources? How can I learn this? And how can I learn this quickly and get them that information? So I think that was the biggest stumbling block, is you quickly develop where you can go for resources. You may partner with some units better than others, some leaders better than others, and you go to a new facility or a new job, and it's kind of a fresh start. And also the title, when I was an intern, they weren't coming to me with, hey, we have this resistant organism, what do we do? It was usually they'd go to them. So I was Johnny on the spot at that point. So being confident, I think having the confidence to know what you're doing, but also studying up enough to that point, I think that was the difference of my knowledge started actually getting tested versus I could be in the background a little more when I was the intern as opposed to the IP.
Yeah, no, that makes a lot of sense. And it sounds like in your career, at least, you had a pretty friendly MPH culture. I mean, if they're willing to let you hang around for a year and a half, and then your first job, the director was an MPH. So you may not have ran up against a lot of the resistance that maybe others have. But I am curious how you learn the clinical piece, or how you gain the clinical experience that a lot of folks really look for.
Yeah. Great question. I think that, and that's still to this day is a massive stumbling block, is that sometimes perceived lack of clinical and actual lack of clinical experience. The way I overcame that is, one, I partnered up with seasoned ICU nurses, and when I first started, and I made it very apparent to my director, I need to learn this. So I'd sit on the ICU with them and with the charge nurse, with an ICU nurse, and go in and out of the rooms, follow them. And I would tell them, I'm going to ask questions that are very intuitive to you. I don't know it, but can you explain it to me? So I was very open to saying, I don't know this, but I'm going to ask you to teach it to me so I can speak with you about it in the future, or I can speak with another nurse. And that, yes, I'm not going to have 100% of your nursing knowledge. I'm not going to be able to start drips and titrate and do all of these things, but we can have a conversation where we're using the same language. But also, I want to see, how do you interact with the patient? What do you see from what are your priorities when you come into this room versus what I think your priority should be? Because sometimes I was like, there's a shift. I'd see a dressing that wasn't taken care of the best. And my thought is, why aren't you taking care of that immediately? And then they'd say, well, the alarm's ringing here. This is wrong. This is wrong. And it was a mindset shift that I had to learn, of how do they prioritize versus what do I prioritize, and how do we meet in the middle? But that I partnered with vendors. A lot of our vendors came in for education, and I shadowed them. I was like, hey, you're an expert on this product. What do I need to know to maybe even know more than our nurses do about this? And I can maybe teach them a nugget of information. They're going to say, well, Marko knows about this. So building those relationships, but being open to continual learning. You have to learn on the job, especially being a non-nurse. There's a lot of clinical you're going to have to learn, but seeking it out. You have to be proactive. You have to go out there. Nobody's going to tell you about it if you don't ask. And if you go in and assume you know, you're going to get it found out real quickly. So don't be afraid to say what you don't know.
That's fascinating. That's a really good answer. All right, let's jump back to career. So you ended up in Jacksonville, IP, large team, level 1 trauma. How long were you in that role?
So I was in that role close to 4 years, I believe. I was there for 3 years and 10 months. Um, and good amount of time spent. I'd say like I had a pretty easy transition due to the internship, but uh, getting my feet wet, we opened a second freestanding facility, another hospital. So it was interesting because then I got the experience of how do two campuses work together but function separately. We had a level 3 NICU, so definitely kind of compiled a lot of experiences in those 4 years before I took my next step during COVID to be a director.
Okay. So then, listen, so you said during COVID. So was this right at the heat of COVID you left and grabbed a new job? Is that
Not right at. So COVID was February, March 2020. I was there through the beginning of August. So helped the facility adjust. Definitely on call during those days when we had to test fax sheets to the Department of Health to get approval for testing. The mask shortages. We got creative with some reprocessing, but used University of Nebraska guidelines building a UV reprocessor. Definitely had to pivot to more of an operations perspective of how do we keep things running while keeping everyone safe. So did that until about August when it definitely started becoming a little more not comfortable, but the routine was there and individuals were more accepting of the change. And then I got the opportunity to transition to another facility in the area as a director and lead my own team. So it was a great opportunity to come in with a newer IP and then also with the ability, the position was there to hire another IP and train one. So I took that as a challenge I would have wanted. So got hired on and
awesome?
started August 2020 with Orange Park Medical Center, Orange Park
Okay.
Hospital now.
Okay. So what was that? Is how did that go down? Were you looking for the next step? Were you looking for a local director position, and then it just happened to open up in August, and you threw your hat in the ring, or was it more of a networking thing, or how did that transition happen?
Yeah, so through our local APIC chapter, we were always involved. I held many positions, so I kind of met a lot of the individuals, and we always announced these openings. And there had been previous openings in the past, and you're always aware of what's coming and going. But I think this was the first one that when it presented, it was a younger team. I knew some of their quality team. There was a new IP, and I thoroughly enjoyed teaching and coaching, and the ability to grow the team as well. And I thought this is definitely somewhere where I can apply. And there was risk; it was succeed or not. There's definitely it wasn't a guaranteed spot where I come into an established team with long-term IPs. It was let me go to a place where I can make it what I think an IP program should look like. Take some of the best practices I learned at my UF facilities, and also teach new IPs because at that time it was scarce getting a seasoned IP to transfer. So I knew I was going to probably have to train nurse, which I ended up getting a charge nurse to be my second IP. And I just looked for that challenge and it worked out.
That's excellent. So okay, so you're there. You stayed in that position what, a year and a half or so?
About a year and 10 months, yes.
A year and 10 months. Okay. So then, and I'm just looking, kind of referencing your resume here. So you made, and this is one of the more impressive things that I've seen, but you made quite the jump, right, from your director position at a mid-sized facility to what's a division AVP within a division within HCA. So how did that go about? And then I'll kind of take a step back and ask a couple of questions.
Yeah, not a problem. So it was, like I said, about a year and 10 months of that position. Other AVPs have been open. And while I was at the facility, I constantly evaluate my skills, where I take the APIC competencies, where am I lacking, where am I not. While I was a director there, I was reaching out to both my current AVP in that position, who was definitely a role model to me. She led me through a lot of difficult situations, but a lot of times when I was asking her questions, it was more of just confirming that what I was doing is correct, just to make sure I'm in line. And I think that made me feel like maybe I can take this next step. I'm already thinking at the same level, and she's agreeing with a lot of the plans I present her. I was working with our corporate members on a few projects here and there, getting in touch with them. And the way they were thinking about IP was similar to the way I thought about it. So I was like, maybe I'm not too far off this thing. Maybe I have a chance there. So one of the things that interested me is Capital Division's fairly large, fairly diverse, and so when it came open, they have a great quality team here, and I'd heard that this team is very productive, very aggressive on HAIs. We have a policy that everyone's an IP, and that's something from my DCMO, my DVPQ, our division president. We push that message down. That doesn't mean just the IPs or the IPs. Everyone from EVS to your C-suite, we're all IPs. We all have a role to play, and they push that message at all of our meetings when we need help with HAIs. And I knew that about this division, so I was like, let me shoot my shot. And luckily, interviews went well, and at where I'm at right now in Richmond, Virginia.
Wow. Okay. And then to your point, you mentioned it earlier about kind of being open to relocation or going around. What's kind of an unfortunate truth about infection prevention that I've seen is if you really want to advance your career quickly, you're going to have to be willing to kind of relocate or change hospitals in order to do it. And if I remember right, you're pretty ingrained in Florida and then ultimately took that role. But can you talk, a little more personally about like that transition and just like leaving town, starting a new place, and just how you weighed the benefits and
Yeah, absolutely. So I think you hit the nail on the head. Florida since I was 6 years old, coming from Europe, and that's all I knew. Florida, the whole time I knew all the Florida's hospitals. I had people in every city. Obviously, the position and the title that came with it, and the challenge. I'm always one who seeks a challenge. Were definitely the biggest factors that drew me into this position. Locale, I think, as you mentioned, IPs to progress have to move. But one thing that I set a range. Where am I willing to move? And I think knowing that in advance is going to help you look, because if you're sitting in a town or a city and you're saying, I'm only willing to move within the city, you're just waiting for that opportunity. But if you expand your grid and you say, I feel comfortable from here to here, and for me, that was a car ride away from my family and friends or a short plane flight, it made it a little easier, but also then broadened my scope of opportunity. For example, in the Southeast, you have major cities, Atlanta, CDC's there. We have a lot of research and great hospitals in North Carolina. My top limit was DC, and I almost got there. So we had a lot of great facilities. And I think if you look anywhere in the United States, if you expand your range and say, what are you willing to do? You're going to get a lot of great hospitals within that area, but you have to your point, be willing to put it in. But definitely some factors that we sacrificed is established friend groups. We got here, and you have to network really quick. And I think that's something we did. Join local groups, be it work groups and also outside groups. What interests you? I'm a big runner, so joined the run clubs, met friends through that. Also moving, looking at definitely what position you're at. We had a house we had to sell. That was also a factor. So weigh your factors. What are you giving up? What are you having to do? And then for us, it was, can we recreate what we had there? And if not, put us in a better place. And ultimately, when we weighed the pros and cons, we ended up at a better place being here at Richmond between job, situation, and about a year and a half in, we have a great support system and friend group. So just definitely put yourself out there when you go to a new city.
Wow. And then just to clarify, can you go over what exactly you're over? Like what's the scope responsibility in your current role?
Sure. So currently my division, we cover 18 facilities in 3 states. When I'd gotten here, it was 4 states, 19. HCA moved Kentucky to another division. Currently I cover New Hampshire, Virginia, and 1 facility in Indiana. I'm the dotted line to all of our infection prevention departments within the facility. Most of our IPs report to the Vice President of Quality, but I am their support system, their knowledge base. Anything that comes out from our corporate gets filtered through me. We make sure all of the materials work for their markets, for their locales, for their supplies. Again, being over 18 facilities, you have different supply centers, different supplies, different abilities to use these supplies, and different understandings. So 18 facilities, mostly located in Virginia. We have some near DC, Central Virginia, where I'm at, in Richmond and the surrounding cities and towns, and then Southwest Virginia, Roanoke, Blacksburg, our major facilities. And then New Hampshire, near the coast, we have 3 facilities in that area, and also 1 behavioral health facility. So that was a learning curve for me because I had not been too familiar with behavioral health at the time. So figuring out what do they do in terms of IP, where can I support them?
Gotcha. Okay, so I just want to make that clear, because this is, again, for somebody to go from staff level IP 2017 up 5-6 years later to be over 18 hospitals, it's a big jump. So I want to know how you did it, and we kind of have learned a little bit through, but you've hit on a couple things that I really want to hone in on, and one is kind of the extracurricular things that you do within infection prevention. I mean, you've mentioned being involved in local APIC chapters, so I want to hear that. You've told me previously about just trying to get on. I don't know if you've got publications or if you just tried to help whoever you could, meet whoever you could within HCA. But I just want to kind of hear, outside of the 8-hour a day job or however many hours a day, kind of what additionally you did that kind of made you stand out.
Yeah, and great question, because that is part of the success is the extracurriculars. How do you put yourself above and beyond? So firstly, to APIC, when I was part of the Chapter 50 APIC in Northeast Florida, I held positions of social chair, then I was the treasurer, then president-elect, and then actually president my last year in Jacksonville, Florida. So very involved, went to all the meetings, was president during COVID, so definitely an interesting shift of how do we keep attendance up, how do we keep individuals engaged. Other things that I was involved in, publications. Great way to start small, letter to the editors. Read your local agent journals, your JAMA. If there's anything that interests you, it's called respond to the author if you have questions. Audit the paper. It's a great way to start slow. It's about a 1-pager. You can get published. You can have some back and forth with the authors. I published some of my research. We were trying to do predictive analytics to predict multi-drug resistant diseases during admissions. We tested the model, didn't really carry it forward, but published on that. And then finally, your national APIC, something that a lot of newer IPs, I believe, are probably a little hesitant of. It's this huge thing, like, how do I get involved? When you go there, everybody knows everybody somehow, and you feel like the odd man out. But what I did was my first year, and I was encouraged to submit something. I submitted on my predictive analytic model, like, how do we look at CRE carriage in the ED? How do we catch these patients? And I got to present. I got a 30-minute podium on that my first time around, and ended up winning the new young abstract presenter of the year at that APIC. So wow. that definitely is a nice springboard and a stepping stone, getting that established award, something behind your name that says, hey, this individual knows what they're talking about, if he's talking to other IPs about it. And then I proceeded the next 2 years. I had another speaking engagement. I presented several posters. My team at UF, we actually won the IP team of the year. I believe it was in 2018 or 2019 at APIC as well. So to your point, the exposure outside of just your facility, how do you network? What are you doing? It is definitely beneficial. And then the first thing I did when I joined here was found my local APIC chapter, and I've already submitted my name to serve on the board. How do I help progress this APIC chapter like I have in Florida?
Wow, yeah, you're doing a lot. I mean, you can see why you've advanced the way you have. So that's awesome. Clearly, along the way, you've gotten, and you've referenced it throughout, but you've gotten some very good guidance from a lot of people, it sounds like, and some strong recommendations as far as what to do, what you can help with or whatnot. Could you, I don't know, maybe pick 2 or 3 people that you really admired or learned a lot from, or really kind of took your arm and helped you through it? Can you just maybe mention those people by name, where they're at, and just kind of what specifically they did and why they were such an impact on you?
Yes, absolutely. So I think first and foremost, the one I have to recognize is Dr. Cindy Prince. She's the professor who I believe now is the chair of the MPH program, or is involved with academics at the University of Florida. She had been an IP prior. She was the first one when I walked into my first epi class of masters, and I said, I want to learn about IP. She introduced me. She made that connection. but she also advocated for me to push and to try to do research and publish and get as involved as I could with that department. She was my chair for my thesis defense. She was super helpful. I still try to keep in touch with her, but definitely she was a supporter, the person in my corner when sometimes I felt like I don't even know how to break that barrier. I came into a program where my MPH was um, my Master's of Science was psych focused. A lot of the research there was going psych, and I was trying to go the hospital route, which they hadn't seen a lot of. That program was more of get your PhD after you get your master's, while I was trying to get into the industry and try to work. So she helped me navigate that. She helped me break some of those barriers and also find where my resources are, connected me with the director. And I think she's somebody who I think a lot more universities need individuals like that who are going to push their students. What do you want to do? How do I make that happen for you? So she's one.
Yeah.
The next individual was the first IP who kind of took me under his wing, John Delano. He is now a multi-site director in Chicago. But when I met him, he was just the IP he was just an IP at the facility at UF Health in Gainesville, and he gave me every opportunity. He said, "What do you want to learn?" And I sometimes would ask him, "What do you think I don't know?" And he guided me. Sometimes he sat me down and said, "I don't think you have a good understanding of this yet, even though you do." And he challenged me a lot. He said, "I want you to learn this, and I want you to learn this inside and out so you can sit at our HAI meetings and talk to it." He brought me with him to talk to the ID doc. He brought me into lab and said, "Hey, Marco's going to answer some of your questions." He put me in the spotlight and said, "You're going to need to know this because they're going to ask you to be the expert." So he challenged me. He pushed me. He also, I will say, put in a good word. I used him as a reference for my first job, and he, from what I heard, he spoke glowingly of me, and somebody I still keep in touch with, a good friend. We talk about everything IP and not, so great contact to have. And then I think
great.
finally, yeah. And then if you want a third, I'd say my combo AVP of infection prevention, and also we had a division director of infection prevention when I joined HCA Capital Division, Rachel Long and Colleen Bartier. They were great support systems, but also they both pushed me to expand my horizons quickly in HCA. They put me on committees. They put me on corporate meetings with our, we have one IP out of each 15 divisions gets to sit with our corporate partners and discuss ideas. That is a very prestigious position, and they put me on that. They encouraged me to challenge myself, take on projects that maybe would not have been within the IP space, but also were there when I hit roadblocks. I think that's ultimately what I think I appreciated the most was, hey, I'm stuck here. I'm not getting traction. What have you done in the past? So bouncing those ideas off of them. One of them was a non-nurse, the other one was a nurse, and one of them was a joint commission surveyor at one point. So I had such a wealth of knowledge, and they helped and they supported me. And they supported me to get this position because put in the good word that they felt like I was ready for the next step.
That's awesome. That's awesome. I've got a couple questions on your position now. Number one, I want to get into how you impact the culture of a facility. So obviously now dealing with a lot of hospitals under your belt, I imagine, correct me if I'm wrong, but I imagine the culture's probably a little bit different in every facility, and there's just kind of unique pieces to it. So I want to know, how do you and your team go about changing the culture of the hospital? I mean, ultimately to encourage patient safety, but just how do you change the image of infection prevention, not to kind of be the police, but more of a partner?
Mm-hmm.
So how do you go about impacting culture change within each facility?
Yeah, and to your point, it's hard. I'd say when you look at it, my position, I sit centralized. We actually don't sit at a facility. We sit in a centralized building in kind of in between, or the best location. The way we do it when I got here was I took site visits. I went and we had different cultures. The culture in Southwest Virginia and the culture in New Hampshire are completely different. The way we approach it, the way we work with our teams. So what we do is I meet with all of my IPs once a month. I meet with the leaders more frequently, and we listen to what are your needs, because when you have 18 facilities, almost none of them are going to have the same needs. There may be some overarchings, but their fires are different. So what we do is we act as a conduit to get their leadership in, because our title and our name carry some weight. So if it's a problem that I think is big enough that I think your CEO or your CMO or your CFO need to be involved in to maybe bridge a gap on a product or get some traction with a physician group, we do that. We serve as your safety blanket, and as of a you tell us your problems, and we'll also be your sounding board of, is this really a problem or is this something we can solve a different way? So that's one thing we provide. The other thing is, again, during those visits, we are there. It's almost consultative. They a lot of times ask us to come and help with an issue, but during that time, we're building those relationships. I make an effort and say, where do all your directors sit? Let's go to their office. Let's knock on the door. I introduce myself. Hey, I'm Marko. You've been on an HAI call with me. I get it that at that time it was a negative thing that we were discussing, but I'm just here. What are you proud of on your unit? So we are very heavily focused on promoting our IPs and saying, every time I leave a meeting with an IP I'm with, I say, you have the best expert here. This is your resource. So promoting up, I think, is great and something that every leader should do, but we have a job to do that across 18 facilities with every leader we interact, and making sure that our IPs feel like they're the subject matter expert. So again, to your point, the culture is different. So what that means to each one of them, I have to sort out, but they ultimately all want to be a resource for that facility.
Gotcha. What, being over that many facilities as well, like I said, I know kind of early on, you had much more of a supportive environment with your educational background versus being a nurse than a lot of people. But in this role, being over this many hospitals, I imagine there's probably at least a couple facilities that probably give you a little more pushback, not having the clinical experience that a particular person may think you need in order to kind of tell them how to do it. And I understand that you're not the person doing rounds in the hospital. I mean, you've got a team to do that for the most part. But have you dealt with any kind of pushback with your educational background?
At this point, I've been fortunate enough not really to have had that. I think when I came in, my DCMO was super supportive. He was on all the calls with me, and he did the same that I did to my IPs. He promoted me up. And then, as I said, when I visit, the first thing I always do is, let's go rounding. I'd go, let me go round with your EVS. Let me go round with your nurses. So I definitely brought it back to, I want them to see me as a partner. And also with their leadership, I'd go to their morning huddles. When you meet 7 a.m., I'll get up at 4, I'll drive across the state because I want to be there. I want to talk to your nurses. So I think that builds a lot of credibility, just showing up and saying, I'm willing to get down in the trenches with everyone and not just sit up here in Richmond and say, oh, I know how you're doing it. Let's just do it this way. It'll solve our problems. That's not going to work. They're just going to say, well, you don't understand our process. So I've prided myself on always trying to do the job I'm asking them to do. And I think that's helped me overcome a lot of those issues. But yeah, support is critical. To your point, when I first started, I did have some individuals, I'd say they were wary more than unwilling. They were just wary. They'd ask. And also my age, I'm a bit younger than the individuals they're used to seeing in this position. So some of the age and some of the educational background did make them wary, but ultimately when you kind of help them through a few issues, it kind of all goes away.
Gotcha. Then the other thing, just with your organizational structure, and it's becoming common to not have any like true direct reports and your team kind of reporting up through the individual health system, up through quality for the most part. I'm curious how difficult and how have you gone about commanding the respect you need in your position without having a direct line? I know when people start entertaining a more of kind of a corporate level position or system level position, this can throw them off a little bit because it's like, wait a second, I've gone from having 5 or 6 direct reports to nobody. How does that work? How do I get people to listen to me if there's not a direct line? And some of this has more to do with kind of the overall organization. But I'm curious as to how you've gone about kind of making those relationships and really functioning as a manager, even though there's not a direct line to you.
Yeah, so I think the first thing is just establishing that relationship with the true leads of your of the directors reporting to you and the IPs reporting to you. So I have a great relationship with all my vice presidents of quality. I meet with them. Something I always ask them is, how can I support your team more? So I think they have the understanding that Marko's here to support us, and that if he's contacting me with an issue, it's likely something he believes is going to impact the whole facility. So having their direct report be supportive and understand what our mission is, and something I always tell my IPs, ultimately they're the expert in their facility and it's their final decision. I think that's also got me a lot of credibility with them, that I will support you through any choice you make. If you tell me something I don't agree with, I'm going to give you feedback and we're going to talk through it. But if you still think it's the best plan, as long as it's not something that we're going to have to that's going to cause patient safety or patient harm, I'm very open to allowing different ideas, and I think that's helped as well. I let them experiment. Trial and error sometimes. If it's not going to work, let's try your process. Did it work? No. Let's come back. Let's try mine. And I think through that process, I haven't come in trying to manage. I've tried to come in and partner. I'm not leading these individuals. I'm partnering and being a support system. And that's helped me function in this position to where they see me as a partner and a resource, versus they don't need leaders. They have enough leaders in their facility, but they need somebody who help them navigate that, somebody who's been in the facility and who's done it. And I think that's kind of how I've managed those relationships without actually having that true power and perceived direct line, more of a dotted line to me.
Gotcha. That's good. And then this is changing topics a little bit, but you mentioned back maybe in your first director role that you were, or maybe your staff role that you were at, but you mentioned kind of looking at competency score or scorecard or something and grading yourself. Can you go, what is that first off? And then can you go into detail as far as how often you did that?
Yeah. So APIC has a competency. It's the new IP competency model on their website. You score 0 to 5, how comfortable you feel in several areas. I think it's targeted towards certifying for your CIC, but it has areas such as how do you, within employee health, do you know about needle sticks? Do you know about exposures? Then it goes into sterile processing, how comfortable you feel. It's kind of a broad blanket, and then you rate yourself. And if you're very honest, it can give you a guide for next year. Where am I going to rate myself? At first, I didn't do it as much, but every year I just try to sit down personally and say, let me take this, let me find my gaps, and try to, how can I close them? And when I was at the facilities, trying to learn about where those areas were is a great tool. I use it as a competency model with all of the IPs that I'm over. If you're not certified, I ask them to complete that, and the directors, and then the directors complete it with their staff if they have staff underneath them. It's a great tool for any new IP, just to kind of assess, where am I at? And I tell everybody, a 1 is not, I'm not good at this. A 1 is, I just need to study more. And I think switching that mindset has really helped them to take an honest look and say, where am I struggling, or where is my knowledge gap and there's a future section where you rate yourself to say, what do I want to be at this point next year? And I'd say doing it annually would be a great start for a lot of IPs.
That's great. I haven't heard that before. That's a good thought. I think the last thing that I have, and then I kind of want to make sure that we touch on anything that you're particularly passionate about and want to share, but I do kind of want to hear, I mean, you work hard, you're creative as far as how you go about things. So I'm curious as to what you would recommend. Let's say a smaller hospital, they have a sole preventionist, but it's a staff title. They don't really have a seat at the table or any real kind of decision-making power. They're not respected as much as they should be, reality. What suggestions would you have to somebody in that situation, either to gain more respect or more influence, or just, I don't know. What would your advice be to anybody kind of dealing with that particular situation?
Yeah. And I think a great thing to realize at that point is, do you have that influence? So for those individuals who have realized, hey, I may not have the influence I want, that's a great first step. But then after that, you want to go to your partners and I always say, if you have a director who you think you don't get along with, go to them first and say, how can we partner? And don't be afraid to partner with nursing, with radiology, with your C-suite, with your case management. There's something we can always partner with. So slowly but surely start building those relationships. It's not going to happen overnight. You're not going to get a seat at the table overnight, but the way to get that seat at the table is for your name to come up in conversations. If the nursing teams are saying, well, Marko helped me solve this issue, and then another person says it too, the CNO is going to take note. Hey, there's an individual who's really helping my teams get to where they need to be. Same thing with your COO. If you're working with radiology, how are we making sure they're safe and isolation signs are getting down to the radiology suite so we're not exposing their staff? How do we foolproof that? They're going to say that. How do you partner with your facility? So building those those direct relationships first will help you expand to the larger ones. And then surprisingly, your admin teams will come to you and when they may have an issue. So start small. Just start asking the people you work with, how can I help you? And then just keep doing that. And then if there's a big issue that you notice, don't be afraid to just go to that individual and say, hey, I've noticed this. Would you like my help? But if you're taking care of it, that's fine. But I have a resource available. If you make sure you're known at the facility, if you sit in your office and you don't get out, unfortunately, you're really not going to have a seat at the table. But if you're out there talking and working and improving things constantly, it'll be miraculous.
It's good answer. Okay, I think I've got through kind of most everything I wanted to touch on, but I want to give you a chance. Is there anything I don't know, is there anything you've worked on publication-wise or poster-wise, or just things that you've learned recently that you really want to share, or just make sure we have a clip of that could potentially get out there?
Yeah, I think just this is back to my passion is getting individuals into IP. I know my path is very odd and rare. So I think anytime I talk to MPH students, I encourage them to reach out. So any MPH students who listens to this, please feel free to reach out to me for advice. I'd love to talk to you. I'll give you time. I'll put time on my calendar at 15 or 30. But don't be afraid to go to an existing IP department and say, I'd love to learn. Partner with them. Early in my career, I got told a lot of times, you're not going to get straight into IP. You have to start at the health department, which the health department's a great resource and a great start for a lot of individuals' careers, but you can get into IP. So position yourself well, do extracurriculars, join your local APIC, even if you're in your master's program. They're not going to stop you. They'd love to have you. They'd love to teach you. Connect, partner, learn, start learning. There's the new certification program. There's the CIC. There's the associate degree that you can get. So that's a resource. So there's a lot more resources coming out on how to position yourself and make yourself more competitive. So don't feel discouraged. Nobody starts their career, usually doesn't, in infection prevention. Most of us come to it after the fact or find out about it later on and then switch. So if you know about it early on, you're already a leg up. I encourage you to pursue it. Try to apply. You can get an infection prevention job coming out of college, coming out of your undergrad if you have micro or nursing, and if you do your MPH or your MS in Epi or other degrees too. It's not restrictive. Apply. The worst thing they can do is tell you no, but then ask them, how can I be more competitive for your next position that opens?
Thank you for joining us on this episode of Voice for Infection Prevention. We hope you found our discussions informative and insightful. Remember to subscribe to our podcast for more conversations with experts in the field, and don't forget to leave us a review to let us know what you think. For additional resources and to stay updated on the latest news in infection prevention, visit our website at voiceforip.com. Thank you again for listening. Until next time, stay safe and continue your commitment to excellence in infection prevention.